Hi there, Dr. Tansavatdi here. In this video, I will be going over facelift consent, and in every consent process for an informed consent, we like to discuss, as surgeons, we like to discuss what the potential benefits of the procedure will be, the expectations from surgery, the alternatives to having facelift surgery, and the risks undergoing surgery. In this video, I will go over the specific risks with facelift surgery, but there are also general risks that are true for any type of surgery, and that will be outlined at the end of this video. So let's start off with, what does facelift surgery do? Facelift is a procedure that is to be able to lift the deeper tissues and remove sagging skin. So the best candidates for facelift surgery are those patients who have visible signs of aging, and it could be they have jowl formation, they have sagging where they're getting what we call these folds or marionette lines. That could be one reason. Another might be the jowls are extending below the jawline, and this sagging here, the jowls, is another reason for having a facelift surgery. Another reason would be sagging in the neck. Now, some people will say, well, isn't that a neck lift? Terminology, whether it's a facelift or a neck lift, tends to address the same thing, which is sagging skin, whether that be in the face or the neck. When it's primarily in the neck, if I'm extending and pulling the skin up into the face to remove all that excess skin, because we like to pull in the upward direction, that is, I term it a facelift. Whatever term we use, the major role for facelift or a neck lift procedure is to remove any of that redundant skin, the excess skin that's lax, and also to tighten up the muscles underneath that have sagged with time and caused the fat pads to descend into the lower face. So the jowls are actually from fat that has descended from the upper portion of the face into the lower face. Or in the cheeks, you can see the cheek fat pads descend immediately. They go in, and that's what creates these nasolabial folds or the smile lines. They can also, so your jowls can be further back along the jawline and extend down into the lower face. So that's usually the position that these fat pads go, okay? And our goal as facelift surgeons is to raise and lift those fat pads up to where they used to be. That's our goal. So that's what facelift surgery will accomplish, to revolumize the face in its natural proportions and to remove excess skin in the process. So that's that lax skin. Sometimes we may recommend combining facelift surgery with other procedures like fat grafting or eyelid surgery or CO2 laser resurfacing. The most common combination is to perform a facelift surgery with CO2 laser resurfacing, because most of that laxity that's happening, yes, the deep tissue falls, and with it comes the skin as well, but the skin is a separate structure. It's as if, if you were taking a look at a grape, where the grape then turns into a raisin, and that skin has shriveled up and the volume has decreased. Well, for a facelift, we are not necessarily revolumizing, but we are repositioning the fat where it's descended so that we revolumize the face appropriately. But the skin itself can be then stretched or pulled so that we tighten and remove some of those lines, but some of the static lines will still always be there, and that's what the position of a CO2 laser will do. So that's what you can expect from facelift surgery, is that it will smooth out lines, but it won't remove all lines, and that's where maybe a CO2 laser resurfacing is combined with the facelift procedure. So I do want to be clear as to what a facelift surgery can accomplish. So the best candidates for facelift surgery are those who have a face and neck line that are beginning to sag or quite sagging, but the skin still has a good elasticity. If it has poor elasticity, we'll be able to pull a majority of that excess skin out, but it will still relax back down a little bit. And there's always a certain amount of give after the surgery is done, because swelling will stretch that skin, and if you have poor elasticity to your skin, that skin will not bounce back down, it will actually loosen back up, and you'll have loose skin still that you'll say, well, the facelift didn't do what it was supposed to do. Well, no, it did what it was supposed to do, but you swelled from the surgery and that skin stretched, you had poor elasticity, and then it pulls back down, you have this excess skin. So that's what I mean by having the best candidates are those who have very nice, strong skin that has still some thickness to it, that has still some elasticity to it, and where you have good bone structure as well. So if you've lost bone structure and you're very thin and narrow, then that bone structure will also lead to a decrease in volume in your face. That may be one of the reasons why, after we've redraped the fat to its appropriate place, you still look sagging, and that might require that we also add fat grafting or add some volume back into the face in combination. So what are the alternative treatments to facelift surgery? The alternatives I mentioned earlier was a CO2 laser to take care of wrinkles, to take care of fine lines and the lines in the face that happen from repetitive motion of the muscles underneath. That is CO2 laser resurfacing, or it could be a chemical peel. Whatever the resurfacing method of choice that we use, those are alternatives to facelift surgery. Another option might be ultherapy or cool sculpting. These are two modalities, different modalities, and then there's an extra one now that is a newer modality, which is radiofrequency. All these modalities are meant to dissolve or remove fat from areas that are now forming, like the jowls, but they don't reposition the fat. So essentially what you're doing is minimizing the fat in the areas you don't want them, or like the chin area, but it doesn't necessarily move them to the right areas. So that is Ulthera and cool sculpting and radiofrequency. In addition, these devices also stimulate, with the energy that's provided underneath the skin, they stimulate collagen production. So the goal with that is to do a little tightening. That collagen production is essentially also what resurfacing on the skin resurfacing, can do as well. So all these treatments somehow try to stimulate collagen to tighten the skin to give you the improvement that you're looking for. So those are the alternatives. However, they do not address the deeper tissue. So that's essentially what a facelift will do that none of these other procedures can do for you. None of them replace what a facelift will do. Something that's closer in scope would be something called we call face tight, or it's a radiofrequency assisted lipectomy or removal of fat in certain areas that also stimulate collagen deeper. But again, it does not do anything to the muscle. It does not redrape and reposition tissues where they're supposed to be, where they were before and that have descended. So those are your alternatives. Last alternative before I move on is the alternative would be fillers and Botox. And if you've had Botox or fillers before, you know sort of the limitations of what those non-surgical procedures will do. Fillers can do a little lift, they can place volume where you've lost volume, but they again do not lift the tissues where they need to be. All right, let's move on to risks of facelift surgery. So inherent with facelift surgery, we have to weigh the pros and cons of doing facelift and the benefits that you would receive from having a facelift surgery. Because for some people, if they heard some of these risks and they knew that there were potential, you might decide, hey, it's not a good risk reward to having the surgery at this point in time, because the amount of sagging does not bother me enough to have to deal with the complications or potential complications that can happen. So what are those potential risks, you might ask? So the potential risks, the first one would be the injury to the facial nerve or injury to nerves for sensation. Those are motor and sensory nerves. They're separate nerves. The sensation comes from little nerves that are extended up to the skin. And when we raise the skin flap, we do injure those nerves temporarily because those get cut in the process of cutting and lifting the skin flap. When it gets laid back down, new nerve fibers will get into the skin and give you back your sensation, which comes back over weeks to months. Now that is the little nerve fibers that will grow back. Sometimes, occasionally, the incision itself still remains a little numb, even months to years out. That's a potential. Now you have to weigh whether that's a risk that is okay as a trade-off for having the surgery and getting a better jawline and neck. The second nerve that can be injured with that sensation is not just the little fibers, but a main branch of the nerve, which is called the greater auricular nerve branch, comes off the back of this muscle and comes up to give you the supply to the bottom of your ear, which is the earlobe, or up into the upper face, or behind your ear. Those nerve branches can be injured during the time of the surgery. Typically, we avoid the nerve by working around it in the direction where it's not going to be. But nerve fibers, every patient has a different anatomy. And sometimes the majority of patients have it in one direction, but it could be in small percentage of cases where it has a aberrant or different trajectory than we typically see it. And in those cases, that nerve can be potentially pulled, stretched, or cut. And then that could lead to potential for a small area that's permanently numb. And that's something that can be more concerning for men, my male patients, than my female patients. So men, if they're constantly shaving and they have an area of numbness, that could be a problem for them. So that is numbness. Then, besides the sensory nerves now, is the motor nerve branches. This particularly is more problematic or concerning for patients because if your muscles don't move and you have one area that does not move, then it could lead to what looks like you've had a stroke. And so that's not something that anybody takes lightly for having a potential risk after a facelift surgery to take care of something that just they wanted to take care of, but it wasn't actually necessary. So what is the risk of nerve injury after facelift surgery? The risk is less than 1%, and most literatures, if you search, the potential for a temporary nerve injury is 1 to 3%. That's temporary. Permanent injury is very rare, so that is like less than 0.03%. The reason why you could have temporary is there are 5 branches to the facial nerve, and each branch goes through what we call the parotid gland, which is your saliva gland. During facelift surgery, in my approach and in most approaches by other surgeons, we do not cut into that gland. We are above that gland. So those nerve branches are protected. But the further you go out from that gland and go deeper into the face, the more you'll be able to see those nerves. What I try to do is I try to stay right above those nerves, and I particularly see each and every branch as that comes out of the gland and it goes into the muscles of the face. It is imperative that, of course, that I know the facial anatomy, and it's clear that the more we do as surgeons, the more experience we attain as to exactly how to do this so that there's no nerve injury. That doesn't mean there will be no injury, because temporary paralysis can happen in 1 to 3% of the cases. The reason why that happens is the nerves can be stretched. So the dissection process is all done bluntly, nothing sharp, but during that process, the nerve, as it's going in the face, can be stretched during the pull. So that is a potential. That's temporary nerve paralysis. Usually with temporary nerve paralysis, the nerve comes back within about 6 weeks. So that's something for you to know if that does happen in your case. So again, risk very low, 1 to 3% in the cases that I perform. Another risk of facelift surgery is hair loss. When you see hair loss, people worry that it's a permanent hair loss. No, it's not permanent. It's not from the pull of the surgery, should not be done where it has an excessive pull on the hairline. Where we put the excessive pull might be just in the corners, above and behind the ear in a little corner here. It does not have a pull on the hair. But more commonly than not, what happens is when we lift the skin, I work my way under the hair follicles so that when the new skin is placed over, what the skin that I've removed and the new skin is placed over, the hair follicles will be growing through the incision to hide it. That's what we want, to hide the incision. That's what we call a trichophytic incision. But during the process of raising the flap, the hair follicles themselves are very close to that incision, and they can be traumatized just from the act of doing the procedure, that they may temporarily fall out. And that is a temporary hair loss. Those usually come back. That's what we call alopecia, which is a temporary alopecia that can happen. Permanent is very rare. So in my cases, I've never had a permanent alopecia, but it is always a possibility that has to be on the consent. Next thing on that list is the use of platelet gel or fibrin sealant. Some surgeons use a fibrin sealant. I like using a fibrin sealant. And the reason why I like to use it is because it helps to seal the skin flap down. After we've lifted it and done what we need to do deep, we put the skin flap down, and that's a dead space that happens. And fluid can collect in that dead space, and that will lead to what's called a seroma, or it can lead to a hematoma. Hematomas are not very common, but a seroma is more common. And seroma, if it's left untouched, can lead to more complications. So as surgeons, we try to avoid that by diminishing and closing that dead space so no fluid forms in that area. But what a tissue glue will do is it will seal the area, and it's used from human thrombin. So you're going to ask me, well, where's that thrombin derived from? It's usually derived from patients who have donated blood, and then we take that, spin that blood, we remove all blood components and derive just the thrombin part of the blood. So all of the potential for HIV, any concerns for infection are removed. Just for your knowledge, it's the thrombin component of the blood that's used to then create a clot. Once we spray it on, creates a clot and helps us to seal the wound. An alternative to this is the use of a drain. I don't like using drains, but every surgeon's different. The drains are problematic because after surgery it has to be removed and can lead to pain. And it does not necessarily prevent all hematoma or seroma. All right, so the next one on the list for the consent is previous surgical scars. If you have previous surgical scars in the area where you lifted the skin flap, it will cause a tethering and not allow us to pull well enough in that area because the scar is tethering down the site of the pull. So that is for your knowledge to know. If you don't have previous surgical scars in the area we're trying to lift, then you wouldn't have that problem. Asymmetry. So the two sides of the face are not the same. The structure of the face is not the same. Some patients have more volume on one side of the face than the other. Their bone structure might be different. And there is something called hemifacial microsomia, which means one side of the face is smaller than the other. And it can be that incidence is pretty high in the population. So we are actually, most of us have some asymmetry on the two sides of our face. And that is something that can continue after the surgery, that it's still there, the asymmetry. Parotid fistula is the next thing. Parotid fistula is very rare as well, and that complication occurs if we've made a cut into this parotid gland, which is the saliva gland, when we've lifted this flap. Typically, I am superficial when I'm lifting the skin here, and then I go deep beyond the parotid gland so that we never get into the parotid gland itself. But if we do get into the parotid gland, then there is the potential risk for a fistula leading to saliva that can extend all the way up to the skin. Uncommon and it's rare, but I do want to point that out. The most common complication after a facelift surgery is seroma. So that's the next on that list. Seroma is fluid accumulation, which is serum or plasma. So if you've ever gotten a cut And as it's healing, you get weeping from the cut. That's what's, if you imagine what's happening when we've lifted the skin and put it back down, it's the weeping inside the wound that's happening. That weeping is this yellow straw-colored fluid, which we call a seroma. And that seroma will collect in a little pocket under the skin, and one of the ways we take care of it is at your post-op appointment, I may need to drain the seroma, because if the seroma can persist, it can then lead to scarring underneath the skin flap and a longer recovery. So seroma is the most common complication or risk that can happen after surgery, but is very treatable, and as long as we stay on top of it, should not have an effect on your overall result. Recurrence of signs of aging or a redo facelift. So the first 4 to 6 months is what is required for the facelift results to get to its final result. You can have swelling that will go up and down and wax and wane and can affect the outcome of the surgery, and we have to wait for all that swelling to go away. Typically it takes about 4 to 6 months. By that time, at 4 to 6 months, that gives us what your final result is going to be that should last you many years to come. However, I do want to say with the technique that we use here, that I use is a deep plane facelift technique. A deep plane facelift technique, if you look in the literature, in the research literature, the risk of having to redo a facelift, or what we call a tuck-up, is very low. The risk is usually 1 to 3% in that short time period of within a year. The risk with other type of procedures are higher, and that is one of the reasons why I like to do a deep plane technique, for the reasons of longevity for your case, so that you have a long-term result. But even despite doing a deep plane technique, there is still not 100%. So I will have patients who require a redo facelift, meaning one side falls or both side falls, it doesn't hold up within that first year, and there's a potential for needing to redo the facelift. Not everybody will get there, but the likelihood is higher for patients who have thin skin, poor elasticity to their skin, and other signs of aging that are not related to when we talked about the bone structure and the volume. So if you have low volume in the face and there's areas of hollowing, or the bone structure is not as strong, then there's the higher potential for needing to redo a facelift within the first year. And then last on the listed risks for facelift surgery that are specific to facelift is this distortion of anatomic landmarks. What does that mean? Distortion could be so where your ear sets, where your earlobe sets to your face. Some people have it dangling, some people have it where it's just stuck there, or some people have a little bit more shape where it's pulled higher, or the ear could be a little bit longer and pulled lower, or you have a big earlobe. All these different things are specific to your shape, and they can be distorted after surgery, because what we do is we make our incision, we lift the skin away, the ear is separate from everything else, it's dangling there, and then we have to reattach everything and make sure that it mimics everything that you had before. So sometimes as the healing process goes on, that incision or the healing process can pull the earlobe forward or back or up or wherever it might be, and those are the things that we may have to address at a later time. The other thing that can happen is distortion of your hairline. So I like to hug the incision around the hairline, but if your temporal tuft is what we call this is your temporal hairline, or your sideburn can be very low, and in that case I'm not going to put this incision so low into the face that it's visible. We're going to hide it in the hairline, and that could potentially remove some of the sideburn so that it is higher in females, and in men we try to hide as much as possible, but that sideburn can be changed because of the placement of the incision. So those are the potentials for distortion of anatomic landmarks. So that was that concludes all of the specific risks of facelift surgery. There are general risks with all types of surgery, and in that I will detail those that are some additional ones that might be associated with facelift surgery.